So yes, I am an ER doctor by training, and I have become a amateur hematologist over the past 12 years. And now I have the pleasure of running the sickle cell program. It's great to be here. So I do have funding from Heart, Lung, and Blood, Doris Duke, and we do some contracted pharma research for these clinical trials of novel agents with GBT and Roche.
Oh, that's right.
Some of the stuff I will be presenting is also funded by National Eye Institute, and you will see why. Quickly, a background in sickle cell disease. This is the most common inherited disorder of blood. It is mostly most prevalent in sub-Saharan Africa. In America, we have about 100,000 people with this disease, and it is a family of mutations of beta globin. The most well-known, most common, most severe mutation is where codon 6, you have a glue-val substitution, and that causes you to make beta globin S, which causes you to make hemoglobin S instead of normal hemoglobin. And that hemoglobin, when it drops off oxygen, it sticks to itself and its friends and forms these long rods, which then damage the red cell. And that really causes two things, vaso-occlusion and hemolytic anemia. And since this is a disorder of blood and blood goes to every part of the body, we have manifestations in every part of the body, from the skin to the spleen to the brain. But the manifestation that everybody is most acutely knows about is the pain episode. So patients have these frequent exacerbations of their disease that manifest as excruciating pain and causes them to be admitted to the hospital over and over and over again. And that episode is also one of the main benchmarks by which we measure the efficacy of drugs. If they reduce the frequency of pain episodes, they have been deemed by the FDA to be effective. So I wanted to take you on a tour of where research in sickle cell has been, where it is now, in my opinion, and where it is going. And so we'll start with the past. Not enough therapies. So this is the timeline of drug development up to about 2000. You can see sickle cell disease was discovered in 1910, and in 1998, we had the FDA approval of hydroxyurea, but other than that, we basically had nothing to treat the disease. Hydroxyurea is an amazing drug. It works by raising fetal hemoglobin, reducing leukocyte production, and it has been demonstrated in just multiple studies that it reduces pain, it improves organ function, and it makes people live longer. So unequivocally, especially if you have SS, which is the most severe form of sickle cell disease, you should be on this drug. No questions asked. So what kind of research were people doing kind of when I came up in the field and when I was training? It was usually people would find ways to tweak the severity of sickle cell by pulling some drug that was already FDA approved off the shelf and trying it for sickle cell disease. And I played this game too. The way that I approached it was that sickling of red cells is a reversible process. They sickle when they drop off oxygen. They unsickle sometimes when they receive more oxygen. And the lung is the organ that does the reversing of the sickling by putting oxygen back into the red cells. So much of my research focused on the role of the lung and what we can do with the lung to modify sickle cell severity. We started by looking at asthma, and sure enough, my work and the work of many others demonstrated that people who have asthma and sickle cell disease have more pain and are more likely to die prematurely. And the mechanism of this was pretty straightforward. We basically thought that if you have airway inflammation and infection, that would cause you to have areas of regional hypoxia, which would mean more sickling and worse sickle cell disease. When I talk about this, people usually start to ask me about steroids. Well, why don't we give oral steroids for sickle cell disease? And it has been tried. And when you're talking about oral steroids, if you put somebody on sickle cell disease, with sickle cell disease on steroids, their pain will go away. The problem is the minute you stop that course of steroids, they will have a horrible pain crisis, almost invariably. And we see many people with milder forms of sickle cell who've never had a pain crisis in their life that get put on steroids for something completely unrelated and wind up in the hospital or even in the ICU. It's also associated with intracranial hemorrhage. The bottom line is that if you have a condition, for example, asthma, where you may need steroids, we like to go with the shortest course possible. Sometimes we'll use a single day of prednisone and see if that gets you what you need. And if you have asthma, the other thing you might do is just increase your dose of inhaled steroids, because those don't really get systemic until the highest doses. And that would mitigate this problem of causing these horrible pain crises due to steroid rebound. But there's this other issue that, well, it's not just people with asthma and sickle cell disease. Sickle cell is an inflammatory condition, and everyone with sickle cell has pulmonary inflammation, or almost everyone. Certainly, if you look at airway hyperresponsiveness, more than half of people with sickle cell have airway hyperresponsiveness. If you look at mice with sickle cell, their lungs, every last one of them, shows increased levels of inflammation, mostly lymphocytic infiltration. And when we look at symptoms in people with sickle cell disease, we see that there are a lot of people who have sickle cell who do not have an asthma diagnosis that still wheeze and have these respiratory symptoms. And if you follow people long enough, it winds up being about 70% of people have these intermittent episodic wheezing and coughing that is really not associated with infection. Furthermore, the people who have the respiratory symptoms, even if they don't have asthma, are more likely to die. And because of this whole thing, we asked the question, well, if everyone has pulmonary inflammation, if everyone has these regional hypoxia, maybe inhaled steroids could be good for everyone with sickle cell disease. And that led us to my R01, which will be wrapping up over the next year or so, where we're doing a randomized controlled trial of inhaled mometasone, which is an inhaled steroid that's usually used for asthma. We chose that one really just because it's once a day and anything to improve adherence. Some of the preliminary data that led to the R01, we see that there was, in our feasibility trial, which was about 50 patients, there did seem to be a difference in pain for people who were on inhaled steroids. And these are people who don't have asthma. And then when we looked at biomarkers, SVCAM is a marker of vascular injury. It tends to really be a good indicator of how bad your sickle cell disease is. SVCAM was decreased in people who were placed on inhaled steroids versus placebo. We saw a trend towards fewer hospital admissions. And here are some other biomarkers. TNF alpha was down, hemoglobin seemed to go up, and reticulocytes, a marker of hemolysis, seemed to go down. So in terms of the R01 trial, we have enrolled 75 people out of 80. So we're just right there close to the finish line, and we'll be starting to analyze data soon. And lots of other people did this. There were trials of Singulair, aspirin, other antiplatelet agents. Regadenoson is an ADH agonist, I believe. There's just a long list of people who did some preliminary research and then pulled some drug off the shelf. And it's it's great, but the truth is that in today's age, we've had a lot of drug development from biotech, and now we have a situation where we have plenty of drugs and drugs that really attack the mechanisms of sickle cell disease. So while I'm glad I did all this research with inhaled steroids, and it may be a nice way to modify severity with a low-risk drug. It's really kind of stale now, and now we need to address the problem that we have lots of drugs. And so this is just some of the mechanisms at play in sickle cell, and there are drugs either in development or FDA approved already that target just about every last one of these. But the ones that I would like to talk about, because they're FDA approved and they really seem to work very well, is first crizanlizumab, which is a monthly infusion drug, and it's a p-selectin monoclonal antibody. And basically, it decreases adhesion with leukocytes in the vasculature and decreases vaso-occlusion. And you can see on the right that people who take this medication in comparison to placebo have about 50% fewer pain crises. And it also seems to improve organ function. The other one is voxelotor, which is a small molecule that inhibits sickling. And this cartoon shows you, this is hemoglobin with oxygen on it. The hemoglobin drops the oxygen and sticks to itself, but and then you have hemolysis with voxelotor, which used to be called GBT440. That gets in there, sticks to the hemoglobin molecule. And then even when hemoglobin deoxygenates, you do not have sickling. So you have restoration of your nice, healthy biconvex red cells. And sure enough, people who took voxelotor had higher hemoglobins. Their hemoglobins went up, in some cases dramatically. And we have seen this. There are some people who we really call them super responders. And in addition, it wasn't just hemoglobin that went up. There was a trend, albeit a much smaller effect than crizanlizumab, but fewer pain episodes in people with sickle cell on this drug. There's also the other FDA-approved drug is called Endari. It's a glutamine. It's basically a dietary supplement. That's also FDA-approved. So now we have 4 drugs: hydroxyurea, glutamine, voxelotor, crizanlizumab. And then we've got 40 or now 50 in various stages of development. We have this new problem that we have drugs and we don't know exactly how to use them. Which ones go together? Which ones should be combined in which ways? Which ones are, is one better than the other? These drugs are never going to be compared to each other head to head by the drug companies. That's just not going to happen. And it raises the issue of, okay, well, how do you titrate sickle cell therapy now? Well, basically, we take this reactive approach where we check people's labs and we wait for bad things to happen. And we sort of see if your labs get better on the drugs and see if your symptoms get better. It's very reactive. It's very slow. And it will be very difficult just using this approach to figure out quickly, at least, which drugs are the best and certainly which combinations are the best. We are taking this approach, and I just submitted about a month or so ago a large grant to basically do what's called a target trial emulation. We know that pharma will never pay for a bunch of head-to-head randomized trials. So instead, what we're going to do with 8 centers and 1,200 patients is we'll follow patients observationally. As providers just prescribe these drugs at their discretions, patients will cycle on and off the drugs. But what we do is we collect data on these people on the same schedule, using the same method, same criteria as if they were in a phase 3 clinical trial. And then on the back end, you try to achieve pseudo-randomization with data and analytics, with balancing and propensity adjustments and a bunch of innovative techniques, so you can try to achieve the information that you would have gotten from multiple clinical trials by just following people. So that is one approach. And it also will be looking at different types of sickle cell patients, because we know that even though everyone has the same mutations, there really are patients behave differently, or their disease behaves differently. And some of the work we've done, this is a Bayesian cluster analysis by my colleague, who's a statistician at Tufts, where they analyzed the cooperative study and really showed that 90% of patients with sickle cell disease fall into about 5 categories with the way that their labs and complications behave. And so in this very large observational study, we'll be tracking which phenotype of sickle cell disease people have, and seeing if there are certain drugs that match better with certain phenotypes. And in our preliminary data for this study, we looked over a short period of time comparing crizanlizumab to voxelotor in terms of organ injury. So kidney injury would be the graph in the middle. That's urine albumin spilling. NT-proBNP is one of our favorite markers of cardiopulmonary injury and severity. And then on the right is hemolysis. And crizanlizumab seemed to outperform voxelotor in all categories. But this is not adjusted for the different phenotypes. It's not looking at the pattern of super responders for voxelotor. So a lot more needs to be done there. But is there a better approach than just following people? Can we find a better way to measure sickle cell severity? And so that's the next thing that I'll be going into. And I'm going to get out of presentation mode, because this part has so many videos that it makes my computer freeze all the time. So in this section, I'll be talking about another way that we found to measure sickle cell severity, and that's by looking in the retina at the eyeball to see blood flow through the eye. And so this work is largely a collaboration between myself and these top 2 people up here. Richard Rosen is a retinal surgeon who's done a tremendous amount of work across multiple diseases. And Toko is an optometrist by training who does computer imaging algorithms mostly. So she's certainly not working at lens crafters, I'll tell you that. And so they came to me and they said, we have all these imaging techniques and we can see blood flow, and we've seen some abnormalities in people with sickle cell disease. Can we use this for the purposes of research? Does this have any applications beyond just, looking at retinal disease? And so I said to them, well, the truth is, we're not the first people to have this idea. And there's been a lot of research about taking pictures of the vascular bed of the eye with fluorescein angiography, and it winds up being a very late marker of disease severity, because you just see the vessels that have been occluded, and we already have late markers of disease severity, things like creatinine and things like that. So we don't really need another marker like that. But if you could use these imaging techniques to actually measure how much vaso-occlusion is happening at the time, then maybe that'll work. And so we use 2 techniques. The one on the left here is called OCTA, which basically takes a picture of the vascular bed in the retina. And then the other one is adaptive optics, which is the one on the right. And this is basically just watching blood flow through capillaries using a microscope. And so to achieve this, measurement of how much vaso-occlusion is happening. We don't want just one static picture. We took multiple pictures over the course of an hour and computed, we put them together, and Toko wrote a processing algorithm to compute how often are we seeing blood vessels disappear and reappear. And we created something called the intermittent flow index, which basically, it's just summing up all the places on the retina where if a vessel was gone and then it appeared later, or it was there and then disappeared later, those are sort of summed in an absolute value calculation, essentially. And then we determine what % of the retina is affected by these events. And you can see in this picture, there are more vessels on the right side. It's pretty obvious. And this is a patient before and after treatment with hydroxyurea. And if we go down, this is where Toko is highlighting, using her algorithm, areas where red would be a vessel that disappeared, and blue would be a vessel that wasn't there, that reappeared. And those events are summed, and you get a number. And you can see on the bottom here, 2% on the left. So the intermittent flow index for this person here on the left is 2%. This person, same person, after treatment with hydroxyurea, 0.74%. So we've created this metric. In a sense, it's really a biomarker that is measuring something. And it's basically quantifying the amount of vaso-occlusion that we're seeing in capillaries in the eye. Now, we have a few different versions of this metric. There was one where we calculated it within one 10-minute session, between different sessions, one where we added up the pixels, and we played with these different metrics. And really, we asked ourselves the question, is this metric an actual measure of sickle cell severity? And then furthermore, when adaptive optics comes in, when we see vaso-occlusion, we then went with the adaptive optic microscope and watched the same vessel to see, well, what is happening when a vessel is occluded? See the mechanisms that are occurring when vessels are getting blocked. So if you look at the different metrics, you can see that all of them have a stark difference, sickle cell versus control. So they're looking like a very effective biomarker. And sure enough, on the left was intermittent flow index. So these other metrics, while they're good, this intermittent flow index really did seem to be the best way to calculate the vaso-occlusion. But how do we measure sickle cell severity if we're trying to correlate intermittent flow index to sickle cell severity? Well, there is no, there's no single way to say, there is how bad your sickle cell disease. There's nothing, there wasn't really something to correlate with one measure of blood flow to one measure of sickle cell severity until I started working with Paola Sebastiani. And this is actually work that she did before we started working together. She did this with Marty Steinberg. Paola is a statistician. She built this Bayesian network where you basically, she dumped a ton of data from the cooperative study, thousands of patients, to incorporate all these things that contribute or are factors in a measurement of how bad your sickle cell disease is. And ultimately, what it became is a computer program where you punch in all these data points about a patient, and it spits out a number between 0 and 1, which is both a measure of your severity of sickle cell disease, and it also is an incredibly accurate predictor of whether or not you're going to die in the next 5 years. And it was derived in the cooperative study, but has since been validated in multiple other studies. So this really was a good way to have a gold standard of how severe your sickle cell disease is. Of course, you might ask, well, if you have this, then why do you need your retinal imaging? Truth is, it's not that easy to calculate this. And the retinal imaging, you just go into the office, put your chin on the machine, and then we get a number out an hour later. So it's actually more feasible to do retinal imaging than to be calculating the Bayesian network model of severity on every patient. And so, sure enough, when we looked at intermittent flow index and how does it correlate with sickle cell severity, I'll turn your attention to the graph on the chart on the right first, actually. The intermittent flow index had a correlation coefficient with the severity of sickle cell of 0.85, which was way higher than any other marker that we currently use. Hemoglobin, LDH, retic count. So it does seem to correlate very strongly with sickle cell severity. And then furthermore, if you look on the left at patients that we've grouped into healthy controls, mild disease, treated and untreated patients, you can see that the intermittent flow index at the really does seem to correlate incredibly well with how severe and how well treated the patient is. We have one patient who did overlap with the healthy controls, and that was somebody with S beta thal plus, so one of basically the mildest form of sickle cell disease, who got on treatment with one of these, I believe it was crizanlizumab. So now let's talk about adaptive optics, which adaptive optics is our way of using basically a microscope to watch what's happening when we see vaso-occlusion. And you can see the blood flow through these vessels, and as you rotate the microscope, you can see different features of the vessel wall. So we can see red cells. Let's see if I can get this video to go. We can see red cells flow through the vessel. You can see these little guys here floating through. We can also see white cells flowing through the vessel. And how do we tell the difference between red cells and white cells? Really, it's the size. Leukocytes are substantially larger, and so we'll see like little dots that are going to be about 5 to 10 microns across if they're erythrocytes, and then leukocytes will be, more in the 20 micron range. And then we can also resolve empty vessel, which we consider to be plasma space. So just here's some of the things that we found in a case series of patients with sickle cell disease. So here's OCTA, right? We've done OCTA. We see a vessel that is intermittently perfused. Sometimes it's full, sometimes it's not. And then when we go to the adaptive optics, we can see like a peristaltic flow. The flow is not great through this vessel. Okay, so then when we look larger at an episode of intermittent capillary non-perfusion, here's what we're actually seeing in this vessel, which is blocked, is a red cell rouleau. So a bunch of red cells that are stuck together that obviously is going to have difficulty getting through this very small capillary. So that was, in this case, the mechanism of intermittent perfusion through this capillary here was a red cell rouleau. In this case, the blockage was caused by an individual sickled cell, which To our knowledge, this was our first video or the first video in a human being of a vessel being blocked by a sickled cell. So it does happen, and we made the first movie of it. We also have episodes where there seems to be a completely non-perfused capillary. And when we looked at that, so here's a video, what was going on when we saw a completely non-perfused capillary. In this case, the mechanism of vaso-occlusion was that the vessel was blocked by sludge, fragments of red cell and debris that had not yet been scavenged by macrophages or monocytes. And again, this, to our knowledge, was the first demonstration of this mechanism of vaso-occlusion, that blood vessels can be blocked by debris because they have the ability of macrophages to clear this and eat the debris has been overwhelmed. We also saw, this was interesting, a translocation of a capillary that basically got pushed aside. You can see it here, the arrows, that this capillary was pathologically translocated, but then after treatment, it actually moved back. So that was interesting. Another distended capillary with sludge, and I'll show you this video here. And this is what it looks like on OCTA on the left. There's nothing there, and then that's what we see on the adaptive optic microscope. We also see these areas of plasma stasis, or what we called capillary flow voids, where there's just a sort of a circling eddy of blood flow. So that was another mechanism of vaso-occlusion or byproduct of vaso-occlusion that we saw. So another thing that we started to look at was, what about treatment efficacy? Does hydroxyurea, what happens when you're on hydroxyurea? And you can see here a patient with pre and post treatment that we saw blood vessels that were either sludged, that after treatment with hydroxyurea, this resolved. So we saw that. We saw resolution of these capillary flow voids with hydroxyurea. And we also saw reperfusion of empty vessels. So you see here on these red arrows, this was a vessel that was just empty that later on, after treatment with hydroxyurea, was again perfused with blood. And so you can see here that this is again, all those videos were basically looking at this same area of the patient's retina. Reperfusion of a capillary flow void. Now, it didn't all get better though. So patients on hydroxyurea didn't have complete resolution of all their issues. And we did find occasionally new episodes of vaso-occlusion, but mostly by the same mechanisms. We saw new capillary flow voids and new erythrocyte rouleaus. It was just that overall the amount was decreased while you were on after you were treated with hydroxyurea. So those were the mechanisms that we found. I was trying to get in some new pictures because we also looked at this in patients who got gene therapy. And again, we saw dramatic reductions in the amount of vaso-occlusion and the amount of all these mechanisms of vaso-occlusions, but we did not see complete resolution in patients, even patients treated with gene therapy. So it brings up the question, a research question of, are patients even post gene therapy continuing to have vaso-occlusion? Do they need continued treatment to reduce vaso-occlusion? But the other possibility is that the ability of this intermittent flow index to perform as a biomarker at the lower levels, like there may be a lower limit of detection where the test becomes not so accurate when you're getting into very, very, very low levels of vaso-occlusion. And that is why we are continuing to do this research. So this is an R01 that will be funded probably in May. It got an excellent score, so we're very happy to be starting that research where we'll be doing this systematically on a larger cohort of patients. So those are the mechanisms that we found, and we're going to use this this grant not only to just look at the efficacy of this as a measure of severity, but also as a way to determine if a patient is responding to a drug. Can we accelerate the process of evaluating efficacy of a drug to the point where we place you on it and we measure your intermittent flow, and will that be predictive of disease severity and complications being prevented? And we'll be looking at all those things in this upcoming grant. So that's great, but now I'll talk about the future of sickle cell disease, which is the cure. When we talk about a real cure for sickle cell, we're talking about something that's not toxic, that we can give to patients because it's accessible, and that it's scalable. We have cures today. I have 3 patients who've been cured by gene therapy, several others who've been cured by bone marrow transplant. The problem with bone marrow transplant is that it requires a match. There's the toxicity of the myeloablation. And if you don't have a match, the haplotransplants are also an option, but they do have higher rates of graft versus host and other issues. So then there's gene therapy, which you don't need a match because the bone marrow comes from yourself. It has no concerns about graft versus host, which is great, but you still have the myeloablation because the genes, the cells are edited outside the body. So this is some schematics from Bluebird Bio, which is the furthest in front gene therapy out there, and they use a lentivirus, which they fill with a genetic payload. And what you do is you give the patient plerixafor and harvest their stem cells, isolate the stem cells, and then outside of the patient's body, you, as John Tisdale says, you squirt a bunch of virus onto these stem cells and wait for a while as the stem cells are edited, and then you check to make sure that you didn't do any off-target editing. You expand the population so that you have a large population of edited stem cells. Then you poison the patient and try to kill a large amount of the marrow that's still inside the patient, and then you infuse the edited stem cells. And they use a viral vector, but some of the other companies are now using these lipid nanoparticle things, and so it's a rapidly evolving field. And so that's how Bluebird Bio is done. CRISPR Therapeutics is the other company that has cured my patients. They're probably second in terms of the race, but there are many, many others. And CRISPR uses CRISPRs to edit BCL11A, which is a suppressor of gamma globin. So when you edit BCL11A, then you make much more gamma globin, and you develop extremely high percentages of fetal hemoglobin in your red cells, and it is also a functional cure. Here's some of the outcomes from the Bluebird Bio patients. Put simply, basically, once the treatment is done, you stop having complications. And from my 3 patients, all of them have baseline hemoglobins above 13.5. They are completely asymptomatic. The only things we're dealing with in these patients is some of the residual organ damage and iron overload that they've had because they all had severe disease. The problem with gene therapy as it is now is that it's toxic. I didn't realize that we were going to have a lecture about CHIP before this, but CHIP is a big problem because there seems to be an elevated risk of hematologic malignancy after all this myeloablation and conditioning for the gene therapy, and that is a major concern. The other thing is it's not scalable because you can only do this therapy in a place that has basically a bone marrow transplant unit. So you need relatively sophisticated infrastructure. So the holy grail is in vivo editing. What if we could just deliver this viral vector or some nanoparticle or something that would go in and just edit the stem cells in the body? Of course, this is a real challenging goal to achieve. Bluebird is probably never going to be an option for that because the viral vector randomly inserts a large hemoglobin gene. So it really can, the gene for this novel hemoglobin can go anywhere in the genome, and you need to do that outside of the body so that you're making sure you're not having any off-target effects. The BCL11A therapies are also concerning because BCL11A is broadly expressed gene. It's expressed in leukocytes, and you worry that if you have off-target effects or improper editing, that you could wind up with hematologic malignancies. And once you edit inside the body, it's really it's out there, and there's no turning back. So BCL11A is also there's a lot of challenges to doing in vivo editing, which brings me to our work with KLF1. And I start by crediting Jim Beaker and his lab, because most of what I'll talk to you about, is just a few minutes, is work that Jim Beaker did before we started working together. The experiments we have now are really ongoing, not ready to present. But Jim discovered with some other people this gene KLF1, which is a regulator of BCL11A, and haploinsufficiency of KLF1 in human beings causes people to have elevated fetal hemoglobin, dramatically elevated. The other thing that's very attractive about KLF1 in comparison to the other genes that people are editing is that KLF1 is expressed only in red cells. So editing this in the body may be more attractive, because if the editing goes wrong, you're really only expressing it in actual red cells, this gene. The challenge was that if you completely knock down this,
like to be home,
it is a lethal mutation. And so when Jim came to me about possibly collaborating, it was to show me that he had discovered a way to quantitatively modulate KLF1. So you don't completely knock it down, and you can basically achieve the same degree of expression as we have seen in these human beings with elevated fetal hemoglobin. He does that by editing a site on intron 1. And so editing with talons worked, but there's scalability issues with talons, and the efficiency of the talons was a problem. And so when we switched to CRISPR-Cas12a, we achieved excellent efficiency with the editing, and exactly the degree of KLF expression that you'd want to achieve that sort of non-lethal mutation, partial knockdown, and likely a dramatic increase in fetal hemoglobin. So these experiments now, we're moving into mice and human cells, and looking at gamma globin expression to see if we can achieve what we're hoping there. And eventually, the goal with this will be to explore just directly injected editing vectors that would basically cause you to increase your expression of fetal hemoglobin, which could be a functional cure without any myeloablation or these other medicines that are so concerning. The other really nice thing about KLF1 is that some of the things expressed on the red cell are adhesive molecules. So partially knocking down KLF1 may also modulate red cell adhesion in a beneficial way. So that's your past, present, and future of sickle cell disease. In the past, we were just pulling random drugs off the shelf and seeing if they helped a little bit. Right now, we're looking at retinal imaging as a way to help us sift through all these new drugs. But in the future, I really hope to be put out of business with a cure for sickle cell disease, which I think really we're going to get there pretty soon. Thanks to my team, all the wonderful people who help take care of the patients, do the research, and all the work that we do. Thank you to the patients. And I'd like to just remember Peter Gillette, who was down at downstate and took care of sickle cell patients for many, many years. He passed away recently. And then, of course, Paul Frenette, who many of us know was a beloved person in our field and just had discovered a lot of the things that I mentioned in this talk really came from the discoveries of Paul Frenette. So thank you, and I'm happy to answer any questions.
Hey, Jeff, that was John Levine. That was a terrific talk. Can you comment on the IFI? Does that change with age and like it gets worse as the patients get older? Is it identifiable in even pediatric patients? And have you looked to see how predictive it is of future events?
Right. So in terms of age, the effective age seems to be dwarfed by your severity of disease. We haven't really seen a trend with older patients. And then when we look in healthy controls, we have this index calculated in people up to 80 and 85 who do not have sickle cell disease, and they simply do not have these events. So really, it's not a measure of like vascular disease and injury and atherosclerosis. It's a measure of like stickiness and blood cells sticking together and blocking the flow. So it doesn't seem very age dependent. We can only go down to probably teenagers with this because, well, OCTA we could do, but adaptive optics, you have to like bite down on this mouthpiece and hold still for like a solid like 15 minutes, and it would be challenging for kids. But I think OCTA, you just take the eye drops and you put your chin on the machine. We haven't looked really in kids yet, but we'll probably go down to about the age of 12 in the study. And finally, I think your last question was about sort of, does it predict severity and does it predict future events? Well, all we know now is that it correlates with this score that predicts severity and future events, but that's what we'll be looking at in this R01 that's coming up.
So all this gene editing to increase the gamma globulin, this will be applicable to all other diseases also, like thalassemia.
Yeah, any disease where you could benefit from having a functioning hemoglobin expression. And it has been, CRISPR and Bluebird have also cured patients with thalassemia. I think that's actually a little further along, to tell you the truth. Those are the first New England Journal publications. So yeah, it totally works for that as well.
Any other questions? Thank you very much. This was a terrific talk.
Thank you. It's been a pleasure to talk. Anybody who wants to reach out and is looking for collaborations, I'm always interested. So you know how to find me.
Thank you, everybody. Have a good day.
Okay, bye.